short video has to do with um, heart failure and differentiating between the two types of. The first is heart failure with reduced ejection fraction. And this is with an ejection fraction of less than 40% while responding to standard CHF therapy. Now, some patients have more ejection fraction or a higher ejection fraction, but still considered congestive heart failure. And this is heart failure with preserved ejection fraction, sometimes written as HF lowercase p EF. And this is an ejection fraction of greater than 50%. But often, due to diastolic dysfunction, we are having heart failure. And we treat mainly based on symptoms. Now, what are we treating our patients with for CHF? Now, first-line treatment usually begins with ACE inhibitors and ARBs. And we try to use these medications because they block the RAS, or the renin-angiotensin-aldosterone system. And while doing this, if we are able to block this, this is going to lead to overall vasodilation. This dilation will reduce the afterload, decrease sodium and water retention. So you ask then, why do we do this? What's the clinical benefit? Well, actually, studies have shown that using ACE inhibitors and ARBs will reduce mortality and hospitalization rates in patients that have reduced ejection fraction. Remember, that means less than 40%. It also overall improves symptoms and exercise tolerance as well. Overall, we can also delay disease progression. So, remembering ACE inhibitors are those medications that end in pril, like lisinopril, enalapril, etc. Now, ARBs we use if the ACE inhibitors cannot be tolerated. And many times our patients complain of the ACE inhibitor cough. They can't tolerate this cough. So the ARBs will be introduced instead. These are drugs like losartan and valsartan. Additionally, we will prescribe beta blockers for our patients. And beta blockers, they inhibit excessive sympathetic activation at the beta receptor site on the heart. And this reduces heart rate as well as the oxygen demand of the heart tissue. Overall, this is going to improve the ventricular remodeling of the heart. The clinical benefit of using a beta blocker, especially if started in while stable, the patients that have reduced ejection fraction, again under 40%, they will have reduced mortality and hospitalization rates. We also know that using a beta blocker, think about regarding the mechanism of action, it can decrease arrhythmic risks as well. By doing this, it also improves left ventricular ejection fraction over time. Beta blockers that are evidence-based used for CHF are drugs like metoprolol succinate, not to be confused with metoprolol tartrate. We also can use carvedilol and also soprolol as well. Again, the beta blockers are those drugs that end in lol. We also use diuretics, loop and thiazides, depending on what is working best for the patient and also what their sodium levels are. And these diuretics promote fluid excretion by inhibiting sodium reabsorption. It reduces the pulmonary congestion that can happen, as well as the overall systemic congestion. So you may have patients that can lay down specifically for a long time or not because of this pulmonary congestion, and you may have patients that present with lots of edema. The clinical benefits, obviously, of using a diuretic is to help improve those symptoms. If they're coughing, they have dyspnea, or they have edema, this can relieve this because we're releasing fluid overall. We're trying to reduce fluid overload and manage volume. Now, loop diuretics, these are the most potent, and we preserve these for patients with acute or severe CHF. Think of Lasix or furosemide as your example. Now, thiazide diuretics are used mainly for patients that have mild CHF. And we, most commonly, we would use a hydrochlorothiazide. Sometimes hydrochlorothiazide is actually first line for hypertension as well. Now, though there are other drugs that can be used in addition to the drugs mentioned, these are the most noted. But we can also use sodium glucose cotransporters or the SGLT2 inhibitors. And we can also, there is some benefit from using MRAs, which are the mineralocorticoid receptor antagonists. Think of pregnenolone. So go and do a little bit more investigation of those two latter classifications of drugs. But by far, knowing that ACEs, ARBs, diuretics, and beta blockers are used as first-line therapies for congestive heart failure or CHF is really important. Now, just other notable therapies. They're not first line, but in specific cases, you might see patients on hydralazine, especially in addition to isosorbide. And this is used in African American patients that have reduced ejection fraction. And if they are still remaining symptomatic on the other medications, which are considered standard therapy, we may introduce these things as well. And then digoxin is sometimes used, and this is to reduce symptoms. Also, it helps to reduce hospitalizations, but doesn't have evidence at this time supporting evidence that lowers mortality. If you have any other questions, I would recommend looking into your pathophysiology book to do a refresher on CHF.